Thank you, sir, for those nice words. And it was excellent oration of Dr. Shabu. I was listening, and the hall is packed. Vijay has done a beautiful organization. And my topic, knowingly, he has kept a topic which all of you will be very keen in taking the summary of this. And Dr. Birmani has already summarized that treatment of diabetes in pregnancy is insulin, insulin, and insulin. So I thank Dr. Birmani, Dr. Balaji, and so many leaders of diabetes. I always take Chennai as the capital of diabetes management, not only in India, but one of the best center in the world. Give a big hand to Dr. G. Vijayakumar, who has taken pain to host this beautiful program. My good friend, and I thank all the organizers of 3D-Con and this diabetes concept much before the obesity was discussed last 10 years. This is the 10th annual conference. The dialogue and the discussions in diabetes is rolling. Coincidental, we are now this year in the peak of diabetes management. So thank you, Vijay, and thank you for the initiative. And I'm sure before we move forward, I'll take a just rough impression that how many of you think of oral hypoglycemic agents or oral antidiabetic agents in pregnancy. When you see a case of GDM, you think of a OAD. Please raise your hand. Shamugam is there. Very few, and I'm sure Dr. Bhavatarini will not support us in this regard. And you see, all the patients that you have talked comes with a history of GDM, wants to have a oral drug, isn't it? Patient tells that, koi dawa mein nahi hoga, can't I have a medicines why you're making my treatment complicated? But unfortunately, in human pregnancy, we don't have studies regarding many drugs. And the gold standard is insulin, globally, all over, till now, and it will remain insulin because that is the natural treatment that we extend to our patients. But coincidentally, when some data of South Africa and other parts of the world came to us, that people are also doing good with few of the oral drugs, the concept came, is there a place of OHA in the diabetes pregnancy management? And next 12 minutes, I'll try to answer this, what the scientific committee has entrusted. And the first thing I'll tell, the classification relevant to pregnancy, if you'll see, it can be a type 1, it can be a type 2, it can be a preconception, it can be a gestational. And when a type 2 goes for the pregnancy or a diabetes detected in the second or third trimester of pregnancy, we again classify the timeline, the pre-pregnancy, the first, second and third trimester, the delivery and the postpartum. And you know very well that the BMI more than 25, age more than 35, the prior GDM, PCOS, the family history and the ethnicity are important risks, and those who have these risk factors, deal them little carefully. Anytime you will get a glucose intolerance, because pregnancy itself is a state of glucose intolerance, and many hormones like human chorionic HCl, lactogen, they contribute profusely. The human placental lactogen, the HPL, contribute profusely for the insulin resistance. And this state is a diabetogenic state because all the hormones, say progesterone, say HPL, say the hormones like prolactin, they are all diabetogenic. And the insulin resistance timeline from the early pregnancy, mid-pregnancy, late pregnancy, it goes on increasing. So, in patients who are with us, there is a 50% rise of insulin resistance, and 32 to 34 week is the peak week for this, and almost 70% of the pregnancy are associated with this diabetogenic state that all of us know from our undergraduate days what happens. And gestational diabetes is defined, as all of you know, the glucose intolerance first recognized during pregnancy, typically diagnosed in the second to third trimester, characterized by the insufficient insulin secretion to meet increased metabolic demand. And then if you see the incidence, it is globally 14%, and the risk factors I have already told, and you see Asians have the highest incidence of GDM. Here, the management framework, we obviously consider the lifestyle first, and then I'll discuss about the oral drugs, insulin, the multidisciplinary approach, monitoring, and the target achievement. And in the lifestyle, you know about the medical nutritional therapy, the carbohydrate distribution in the breakfast, lunch, and dinner, and the mealtime strategy, and the plate model, which all of you practice. That's 50% non-starchy vegetable, the lean protein 25%, and complex carbohydrate 25%, and the different precautions like the glycemic index, the micronutrients, the protein intake, and avoiding ketonuria. These are all important parts. Physical activity, of course, will encourage, but you have to take care of the stage of the pregnancy. In advanced pregnancy, you have to be very careful, and it's the same, the 30 minutes per day, 5 days a week, and 150 minutes per total week we consider. And walking, swimming, yoga, cycling, light weights, and the prenatal exercises are taken, which have low impact to some strength exercises, and this is must. I am just touching upon because you should not forget this before talking to the patient about insulin or the drug. And in pharmacologic therapy, it's after the medical nutritional therapy and exercise fails, there is persistent hypoglycemia, the glycemic targets are not reached, and there is patient is symptomatic, there is a fetal concern, and first, as already told by Dr. Bhirmani, we consider insulin. After lifestyle, after the diet and exercise, we consider insulin. But there are few people who were on metformin because of maybe PCOS, because of other indications conceived, and they had reasonable evidence regarding use in pregnancy that I'll show you. So then came metformin to the picture, and this metformin dose usually given is 500 milligram, that is after food in the breakfast and the dinner, you know, it causes GI upset. And then comes the drug like glyburide or glibenclamide, and the insulin I'll touch upon. I'm not going detail to the insulin, but all type of insulin, the basal, prandial, the correctional doses, the monitoring, the hypoglycemia, all of you practice. The oral hypoglycemic in pregnancy, the rationale comes, as I have already told, improved SS, the reduced weight gain. You'll be surprised to know metformin, if a patient takes, up to 2.5 to 3 kilo of weight reduction takes place in a singleton pregnancy. So there is a patient preference, obviously, and cost effective also. And many times, along with insulin, there can be a combination therapy of metformin. And if you see the drug classes, metformin, though crosses the placenta freely, 100%. The maternal to fetal ratio is 1. This every drop of metformin crosses placenta, that I will show you. The placental transfer consideration freely crosses placenta, and fetal maternal ratio approaches 1. But glibenclamide, what we talked, there is a variable placental passage, and the modern assays just show some of the drug, and monitoring they show us the fetal surveillance which is required for the OHA use. But unfortunately, very good drugs what Dr. Shabu were discussing, the GLP-1 agonist, the SGLT2 inhibitor, the DPP-4 inhibitor, the glitazones, the many other sulfonylureas, they don't qualify to be used in the pregnancy. And 85% there is a metformin safety, 70% the glibenclamide safety, and 15% they obviously need insulin even if we go for these drugs. You know about the mechanism of action. I am not telling you about AMPK, but the hepatic gluconeogenesis, the peripheral glucose uptake, the lipolysis, or the GI glucose absorption, they come into picture. Weight loss, the no evidence of fetal or maternal hypoglycemia, and the cardiovascular events reduction makes metformin special in this regard. And the pharmacokinetics is the 2 to 6 hours is the half-life. The bioavailability is 50 to 60% and 90% renal excretion. And it makes it a very good drug in the pregnancy. Placental transfer I have already shown. The fetal maternal ratio is 1, and there is 100% placental transfer. Though there is no untoward fetal reports, there is 100% placental transfer. The safety and efficacy is very considered very safe, and the weight outcomes, there is 2.5 kilo reduction. And if you see the issues, usually we see the macrosomia, the neonatal ICU admission of the baby, the preterm birth, the hypoglycemia, and the cesarean pregnancy. They all are taken. The least complications are associated with metformin. And the maternal outcomes, if you will see, the glycemic control is 85%. There is weight reduction, the GI tolerance is also good, and the blood pressure is maintained good. And you will see the metformin performance, it comes at par with the insulin. You see the graph towards the right, it comes alike with the insulin. And the neonatal and the long-term outcomes also, they are all favorable. And you will see the different effects, like what I was telling you, the macrosomia, the NICU admissions, the hypoglycemia, they are almost at par with the insulin. This all data is at par with the insulin. But if you see the glibenclamide, the two important factors, the hypoglycemia risk is definitely very high, and second is the efficacy and the safety maybe at around 60 to 70%, not more than that. The important is the placental transfer. There is a 45 nanogram per ml in fetal, there is 6.8 brood, and 15% transfer rate. So this much of sulfonylurea is also fatal for the baby, not metformin. So there how you can see here all these issues I told, the macrosomia and the ICU admission and the different factors. The score by the glibenclamide is much higher than that of the insulin. So the glycemic control, neonatal hypoglycemia, the maternal hypoglycemia, weight gain, as well as the macrosomia, they score much less. And the 18% neonatal hypoglycemia virtually tell us not to use glibenclamide freely. And 22% macrosomia rate is also associated with the glibenclamide. And here, if you will see the metformin insulin, I told you it's at par, all the risk factors. You will see the glibenclamide insulin, you see they score very high, much better. The insulin scores much better, and they are towards very bad side. Here, selecting a candidate, if you have to see the GDM diagnosed and between 24 to 28 weeks, The fasting glucose is between just 95 to 106, not much more. The postprandial is 140 to 180 and no contraindication for the metformin, then you can go for this. And the clinical decision depends on these factors. If at all you are aiding metformin or starting with metformin after the lifestyle. The monitoring and the follow-up you obviously know about the SMBG targets. It's very important just for your revision. Fasting has to be less than 95. Postprandial 1 hour you have to target 140 and 2 hour 120. And then this cannot, more than this can be fatal. And these are the guidelines for the use of oral drugs. The clinical scenario, I'm not going in the interest of time. So the practical pulse for the OAD use, I'll tell you my experience. The insulin is obviously gold standard, and at present you can consider metformin if there is a very mild hypoglycemia, number one. Number two, the patient doesn't have any contraindication like EGFR and the hepatic dysfunction. Less than 30 ml EGFR rules out the scope of metformin, and you can combine the metformin along with the insulin. So you have to set clear glycemic targets, that 95, 140 and 120. Dose of metformin 500 milligram breakfast and the dinner, and in 2 weeks you have to titre and monitor the lactic acidosis, of course. And 20 to 50% need insulin supplement, and 24 to 48 hours the GI effects are very important. So I must thank all of you for your time and attention, and the opportunity given by the 3D-Con group for this presentation, and I'll be happy to take up any question. Thank you.